good afternoon. Thanks to the chairpersons and the organizing team. Post lunch sleepy session. I'll keep my talk very simple. Surgery is the only definitive treatment offering cure for GBCA, but unfortunately the cure, this term doesn't go well with GBCA. The cure is possible in very few. And upfront resection, there's also very few, less than 10%. Majority are metastatic, or at least they will be locally advanced. Some of the locally advanced tumors may respond well to a neoadjuvant chemotherapy, so that we can do adjuvant resections later on. But again, this percentage is less. And good imaging is critical to detect the gallbladder cancer. And if you detect, to stage it properly, just rule out the metastases because so high rate of metastases here, and then decide it's a well-confined early one or it's a locally advanced, whether neoadjuvant possible or not. So all the planning of surgery is based on imaging. Now, ultrasound being our first investigations for gallbladder pathology. Normally, it is either of the three, is mass repressing gallbladder, intraluminal polypoidal mass, or wall thickening. Now, this wall thickening can be benign or can be malignant. If we look into our incidental CAGB data, so at least 25 to 30% of the incidental CAGB are actually not incidental, they are missed CAGB because someone has gone for lab chole with some thickening which should have been evaluated but not done. So any gallbladder thickening should be evaluated properly. In this regards, GBRADS, the gallbladder reporting and data system, it helps in risk stratification. There are 6 grades, 0 to 5, and it helps in detecting or predicting the malignancy risk. Now, as the RAD score are higher, say 3, 4, and 5, the chance of malignancy is also higher. It's very less in benign, less than 2%, whereas in 4 and 5 it's more than 50%. Now, the left-hand side picture, this is a GBRAD2. You can see a layered appearance. So any thickening in USG should be properly evaluated. There's a layered appearance is preserved, and there are some intraluminal, there is an intramural cysts. So these are likely benign. These are GBRAD2. If you look at these, this is GBRAD3. There is thickening, asymmetrical thickening, but the interface with the liver is maintained. So this is an equivocal one, but that has to be evaluated further. You need further imaging. And the extreme right, this is a GBRAD4. So there is asymmetrical thickening, and the interface with the liver is lost. So this is likely malignancy. The chance of malignancy is quite high. So if you get a thickening, don't leave it like that. Evaluate further to calculate the risk. So now, USG is not good for staging. It's good for initial identification, but for staging, you need either a CECT or a CEMRI. For our unit, the choice, investigational choice is dual phase CT with an arterial phase 20 seconds and a portal phase 60 to 70 seconds. Now, what we see at the CT, actually we look at the T, N, and M things, okay? Now, the accuracy of the T stage is around 83.9%. The higher the T stage, the more sensitive the CT is. And it's 100% if we look for the hepatic and the vascular invasion. And it predicts resectability in almost 85% patients. We look for the fat planes between the tumor and the adjacent organ or vessels. If the plane is maintained, it's fine. If the plane is lost, obviously, there is high chance that they are involved. Now, we look into the vascular things very carefully. There is loss of intervening fat plane with the angle of contacts. The luminal outline is irregular or regular. There is narrowing of the caliber, whereas the presence of tumor on both sides of vessels, because it determines the resectability. And if some major liver resection is needed, then we need a CT volumetry. That's why CT is our investigational choice. So these are the images. You can see that there is a mass in the gallbladder here, okay? Here you see the liver infiltration is quite big. This type of tumors, I will discuss it later, that you cannot manage with a simple extended coli. You need a major liver resection. But the important city is in excluding the candidates who are not, I mean, you can't operate actually. So this is the arterial involvement here. This is the portal vein involvement. So obvious obvious hepatic artery or portal vein main portal vein involvement that precludes resectability. And here you can see this is a CAGB, but it has a node here. And it was biopsy proven. So if someone has a paraaortic lymphadenopathy, this is an M1 disease, so you can't operate on these. Now, CMR is also equally important. I mean, you can go for both CT or MR. CT volumetry needed if some major resection is needed. Otherwise, MR also gives an equal informations. Though it's a much less frequently used, but it's a more informative tool because it gives a higher contrast resolution, and you can better depict the biliary anatomy. And the availability of diffusion rotated images is an advantage because it has a very high sensitivity in the detection of liver and lymph node mets. Now, PET-CT, it has been shown that it upstages almost 25 to 50% patients that are getting upstaged. So, which is apparently resectable in CT or MR. If you do a PET-CT, even add on PET-CT, you can still diagnose a lot of patients with metastases where resection has basically no role. So these days, many of the times, I mean, we go for a triphasic PET-CT that combines PET and a triphasic CT for the gallbladder. Now, if you compare the sensitivity, more or less CT and MR has comparable sensitivity for hepatic and vascular invasion. Lymph node is slightly better detected in a CT. Peritoneal mets, more or less CT and MR is okay, but still in any operable CAGB, when we decide on CT or MR that this is operable, we always go for a staging laparoscopy because staging laparoscopy also detects some of the non-detectable mets, very CT occult mets. And PET definitely, I mean, we are very much in favor of PET-CT because it upstages the for CAGB. Now, if you talk about surgery, so the role of imaging is basically you exclude metastatic disease or you exclude T4 disease where surgery has no role. But the surgery actually is dependent on the T stage. So T stage is the most important determinant for the degree of surgery. If it is T1A or B, T1A limited to lamina propria or T1B where musculature is involved, no other organ is involved. If for T1A, simple coli is enough. But T1B, you need an extended coli where we go for a 2 centimeter liver wedge excision along with lymphadenopathy, lymphadenectomy. But for T2 lesions, particularly T2B, if the degree of liver infiltration is more, then sometimes extended coli may not achieve the margin, okay? Where some suggest that maybe segment 4B or 5 may be better, but sometimes you have to go for further liver resections, that is extended liver resections. And T3 is a tumor stage where the other organ resection is important because it may involve the stomach, it may involve duodenum, it may colon, pancreas, or the extrahepatic bile ducts. So now the degree of what surgery will be doing, that will be dependent on the T3 stage, on the T stage. So extended coli is basically either a primary or a completion extended coli for incidental CAGB. Pre-op tissue diagnosis we don't do, and we always send the cystitic margin for frozen. If the cystitic margin is positive, we excise CBD. Now, if you look at the degree of liver infiltrations, extended coli is 2 centimeter liver wedge. Here, the tumor has gone much into the liver. So we need an extended resections. Again, a GB neck tumor with any amount of liver infiltrations, because GB neck tumor are very close to right portal pedicle. And there, you cannot have an adequate margin without sacrificing the right portal pedicle. So these are the situations where you'll be requiring more extended resection. Now, we excise CBD. If it is GB neck tumor is very close to CBD, or the cystitic margin is positive on frozen section, or patient has associated colorectal cyst. And sometimes in papillary tumors, it's maybe multicentric, almost 20% cases they are multicentric. So sometimes in papillary tumors also, we excise CBD. Now, what is the role of extended right hepatectomy? If it is GB fundus or body tumor with extensive liver infiltration, GB neck tumor with liver infiltrations, GB neck tumors with Hyder block, particularly confluence block, or there is involvement of the right-sided portal pedicle, either right hepatic artery or right portal vein. We go for extended resection. So here the infiltration, liver infiltration is too much, and here the right portal vein is involved. So in this scenario, you have to go for an extended right hepatectomy. Now sometimes we do extended chole elongated pancreaticobiliary. This patient actually came to me with just SOJ, and someone diagnosed it as a distal cholangiocarcinoma. But when we evaluated, we found that this is actually a CAGB, resulting in there was a direct infiltration towards the distal CBD. So we did an extended chole elongata Whipple's. So involvement of duodenum pancreas, extensive bulky densely adherent nodes which cannot be cleared without Whipple's, or sometimes in papillary tumor, if there is biliary involvement of the intrapancreatic CBD, we go for extended chole along with pancreaticoduodenectomy. So this is the thing. I mean, pancreas is involved here, duodenum is involved. So these are the potential candidates for extended resections. To summarize, how do you decide about resection of other organs? So if it is a liver involvement, we need a liver resections. If it is a well-confined only, we just extended chole is enough. But if the liver involvement is higher or extensive, we need an extensive liver resections. Okay, and it's always an extended right. So right along with segment 4. Okay. Now, if there is bile duct involvement, we excise CBD. If it extends proximally to hilum, we go for a hepatectomy. If it extends distally, we go for a PD, Whipple's. Now, duodenal-pancreatic involvement, we combine EC with PD. Sometimes, if the patient requires a major hepatectomy, then along with this, we call it HPD, Hepato-Pancreato-Biliary. Sometimes only pyloric antrum is involved. Sometimes we go for a sleeve dissection, sometimes distal gastrectomy. And very commonly, hepatic flexion and the proximal transverse colon is also involved. We just do either sleeve or segmental resection, sometimes even right hemicolectomy. Now, all these extensive resections, they need some preparation. So here the role of IR guys. Majority of them, they have jaundice also. So we need a PTBD to get the serum bilirubin down to less than 3. And if the FLR is not good, less than 30%, we go for a right-sided portal vein embolization. And for CAGB, if we go for portal vein embolization, normally we embolize segment 4 also. Otherwise, segment 4 also hypertrophies, and that makes extended resection slightly technically difficult. And we wait for 4 to 6 weeks after PV for the atrophy, hypertrophy to occur. But the problem is CAGB being so aggressive disease, sometimes in this waiting period, patients develops METs when we re-evaluate the patients. So actually, we have very few patients who land up ultimately in extended right hepatectomy. Thank you.